In previous Access Evidence Learning videos, the relationship between systematic reviews and various types of meta-analyses was discussed. We have seen how they can provide ways to synthesize results from different studies in order to draw comparisons between treatments, in terms of efficacy, for example, and inform decisions about their use. This Access Evidence Learning video will focus on NMA, sometimes referred to as a mixed treatment comparison. NMA enables comparisons to be made between multiple treatments, taking into account both direct evidence from one, or multiple, head-to-head randomized controlled trials, and indirect evidence inferred from trials linked by a common comparator. For example, if there is direct evidence for A versus B and A versus C, we can use this to make an indirect treatment comparison between B and C. NMA allows us to build on this by jointly analyzing both the direct and indirect evidence. Applying this principle across all comparators which are relevant to a given scenario, complex networks of evidence can be constructed which allow assessment of the relative efficacy of all treatments via both direct and indirect comparison. One of the most common ways NMA can be used is to assess the efficacy of a new drug, treatment Y, relative to multiple comparators, when, as is usually the case, it has only been compared with a single comparator or placebo in clinical trials. In this example, NMA enables comparison of Y with all other treatments via both direct and indirect evidence. A feasibility assessment should be made before conducting NMA to ensure that the assumptions of the NMA will be fulfilled. One of the most important factors to consider is heterogeneity. If there are large clinical and methodological differences between studies, this can lead to excessive variation in the size of treatment effects, which is known as heterogeneity. In this example, the distribution of disease severity varies between the 3 AB trials and the 3 AC trials. Patients have more severe disease, as indicated by the red figures, in the AC trials than in the AB trials. If disease severity is an effect modifier, meaning that it influences the effect of the treatment, then pooling the evidence from these trials in an NMA could lead to bias. This is because disease severity is clearly different between trials. It might not be appropriate to conduct NMA unless suitable adjustments could be made. During feasibility assessment, differences between studies in terms of treatments and endpoint definitions should also be considered, and assessed as to whether they are likely to modify relative treatment effects. Treatment differences might include different regimens of the same treatment, such as twice daily in one study versus once daily in another, or different dosages, such as 20 mg versus 40 mg. A common challenge with endpoints is that the same endpoint can often be measured in different ways, which can affect the comparability of results across trials. For example, survival can be measured as a time-to-event outcome, such as the time to death, a binary outcome, for example, how many patients are dead at a defined point in time. An endpoint can also be measured as a continuous outcome, such as median survival. In addition, the exact definition of an outcome needs to be taken into account. For instance, in the case of survival, if this includes all-cause death or cancer-specific death, and from which time point measurement is made. If there is variability in the way that endpoints are measured across trials, then it may not be appropriate to include all trials in the NMA. Another important consideration for feasibility assessment is transitivity. This is the only additional assumption for NMA, on top of the general assumptions for meta-analysis. The transitivity assumption states that treatments have the same effect in all studies in a network. In this example, the common comparator, treatment A, should have a similar effect when it appears in AB and AC trials. This may not be the case if, for instance, treatment A is administered as a tablet in AB trials and an injection in AC trials. Performing NMA using this comparator could lead to misleading results. If the transitivity assumption holds true, there will be agreement between direct and indirect estimates of treatment effect. This agreement is known as consistency. Now, let's take a look at some considerations for the analysis of NMA. Firstly, the type of model must be chosen, either fixed or random effects models. In fixed effects models, variation in treatment effects across studies is assumed to be due to chance, whereas random effects models assume that each study has its own true treatment effect. There are various considerations influencing model choice. For example, which best fits the trial data. It is good practice to analyze data using both models and then provide clear rationale for whichever is chosen. The statistical approach to NMA is another key consideration. Statistical analyses may be either frequentist or Bayesian. Both of these can be applied to fixed and random effects models. Finally, an NMA may also include sensitivity analyses. These test the validity of analysis outputs and their robustness if assumptions are changed. They can also determine if a subset of studies has an undue effect on the results. For instance, a sensitivity analysis might explore the effect of using different models, such as fixed or random effects. It could also test the impact of including or excluding trials with different design features, such as those that are open-label. Now, we will look at some ways in which heterogeneous data can be minimized in NMA. Firstly, the impact of study differences can be explored by splitting the network into subsets of studies with similar characteristics, or by conducting a meta-regression analysis, which is a model designed to explicitly capture the impact of potential effect modifiers. Choosing an appropriate model is also important. For instance, if residual heterogeneity remains after adjustments, a random effects model can help to account for this. Although these methods can help to account for moderate heterogeneity, the results of any NMA must be interpreted with caution. Sometimes the data in the network is simply unsuitable for NMA, and it may be necessary to consider an alternative source of evidence, instead of carrying out NMA. NMA should also be checked for agreement in direction and magnitude between direct and indirect estimates of treatment effect, which, as explained earlier, is known as consistency. Consistency can be checked when the network contains a closed loop of interventions, which allows us to determine statistically whether there is agreement between the direct and indirect evidence. If this is not the case, then it may not be appropriate to combine the evidence in an NMA. One important thing to note is that there is no universal best way to conduct NMA. The methods and statistical approach used will be specific to each analysis, and should take account of the clinical scenario, purpose of the analysis, and data availability. Now, let's look at how NMA can be used in a real-life setting, using the example of drug A, a pharmaceutical product for chronic lymphocytic leukemia, or CLL. Drug A is approved, in combination with drug G, as a first-line treatment for adult patients with previously untreated CLL, for whom full-dose drug H-based therapy is not appropriate. NMA was conducted to assess the clinical outcomes associated with various CLL treatment options, including drug A. The primary endpoint for which the NMA was conducted was progression-free survival. The NMA was designed to contextualize the pivotal results of a specific CLL trial for drug A plus drug G, to allow comparison with treatments where no direct evidence existed, and to inform a cost-effectiveness model to characterize potential value for payers. A systematic review identified 16 randomized controlled trials for inclusion. These all either reported a hazard ratio for progression-free survival, or provided other statistics for progression-free survival that made it possible to estimate a hazard ratio. The network of evidence for the NMA included the pivotal results of a specific CLL trial, which assessed drug A in combination with drug G versus drug B and drug G, and versus drug G alone. By combining the direct evidence from this trial in a network with other trials, indirect comparisons could be made between drug A plus drug G and all other treatments. The NMA was performed using a Bayesian statistical approach, and a fixed effects model, with a meta-regression for age adjustment, was chosen for the base case analysis. Meta-regression was used in the base case to adjust for population differences between trials, which may have confounded the outcome. Age was chosen as a proxy of fitness of patient population, since it was the most frequently reported baseline characteristic. The median age varied considerably across the trials, from 57 to 73 years, with the highest value reported in one trial. The impact of the meta-regression was explored in sensitivity analysis. When the meta-regression was excluded, differences in effect size between drug A plus drug G versus other treatments diminished, though the overall conclusions of the analysis were unchanged. Now let's take a look at some of the ways the results of the drug A NMA can be presented. Firstly, as with meta-analyses, a forest plot might be used. In the example shown, hazard ratios for progression-free survival are represented by blue circles and 95% credible intervals. Lines extending to either side are presented for drug A plus drug G versus various other treatments. In most cases, the hazard ratios and their respective 95% credible intervals are below 1, which suggests that drug A plus drug G is more effective than other treatments. The exception is drug K, where the comparison is inconclusive. The hazard ratio for drug A plus drug G versus drug K is below 1, but the credible interval is wide and covers a range of values below and above 1. Secondly, results can be presented using cross-tabulation, also referred to as a league table. In this example, direct head-to-head data appear in the upper half of the table, and NMA estimates are shown in the lower half. League tables typically also report credible or confidence intervals, although these aren't shown here. In order to identify the hazard ratio estimated from the NMA for progression-free survival with drug A plus drug G versus a comparator, say, drug G alone, we read down from drug A plus drug G and across from drug G to find 0.19. This table format allows the estimated value from the NMA to be easily compared with the direct evidence in the other half of the table. In this case, the figure is the same. This can happen when the number of trials in the network is small, meaning that most direct connections between treatments are via single trials. The table also shows that the hazard ratios for drug A plus drug G relative to other treatments are all lower than 1, which suggests this combination is more efficacious than comparators. However, it is important to remember that the credible intervals also need to be accounted for when comparing the interventions. Another way of presenting NMA results is using a rankogram, a graphical representation of the probability for each treatment to rank in each position for a specific outcome, here, for progression-free survival. For example, if each treatment arm in the network is represented by a single line, as shown here in red for drug A plus drug G, we can use the results of the NMA to plot the probability of each treatment being at each rank. Based on the information in the rankogram, likely rankings can then be derived for all the treatments. However, it is important to interpret the rankogram with great care. These rankings are not precise, and may be best thought of as clusters of similarly performing treatments, rather than as an exact hierarchy. In this case, it can be seen that the drug A plus drug G has the highest probability of being ranked first or most effective, but it cannot be confirmed from the rankogram that drug A plus drug G is the most effective treatment. We can infer that the combination is among a cluster of high-performing treatments, but we cannot determine the exact ranking within the cluster. Now, let us look at the overall conclusions that can be made from the NMA. Both the forest plot and cross-tabulation suggest that drug A plus drug G is the most effective treatment in the network, as seen by hazard ratios and 95% credible intervals for progression-free survival which are below 1 relative to most other comparators. This is also supported by the rankogram, which shows that drug A plus drug G is likely to be ranked as one of the most effective treatments. Next, we will look at how the outputs from the NMA were used to inform a cost-effectiveness model, where drug A plus drug G was assessed against several key comparators from the network. The hazard ratios estimated by the NMA were used to derive probabilities of transition between various health states in the Markov model. Drug A plus drug G was found to be cost-effective, with incremental cost-effectiveness ratios of less than £25,000 per quality-adjusted life year against all comparators. This demonstrates the relevance of conducting NMAs. Without the NMA, it would not have been possible to assess the cost-effectiveness of drug A plus drug G relative to comparators outside the results of a specific CLL trial. Finally, we will mention a common application of NMA, the evaluation of interventions by health technology assessment, or HTA bodies. HTA bodies often require NMA to assess comparative clinical efficacy and inform cost-effectiveness models when there is a lack of head-to-head trial data. Although accepted methods for NMA differ, HTA agencies typically assess the quality of an NMA in terms of two criteria. Firstly, whether the question addressed is relevant in terms of population, intervention, comparisons, and outcomes considered. Secondly, whether the methodology used is robust enough to permit a valid conclusion. This video covers the following considerations for NMA: feasibility considerations, such as heterogeneity, treatment and endpoint differences, transitivity and consistency, and analysis considerations, such as model, statistical approach, sensitivity analysis, presentation of results, forest plot, cross-tabulation, rankogram, application of NMA, cost-effectiveness models, health technology assessment.